everybody and welcome. So ultimately, we are now completing our cycle of IRA webinar. When in last August, we have planned how to go ahead. So we had two options, either go with a direction and with a target through the high road, or to go through the lanes and by-lanes to enjoy the journey rather than having an end or having a target. So we have, for the last 6 months, every fourth weekend, we had our webinar meeting on rheumatology and various aspects involving national and international luminaries on the areas, and we had a wonderful around 48, including today's 4 talk. We'd be having 48 talks and amazing talks, both by the national and international, both by the mix of junior people and the senior people, and having wonderful mix of academics. So today we are having our last webinar, and Dr. S.S. Uppal and Dr. Anupam Waklu. Dr. Uppal is a very good old friend of us. He is with IRA for a long period. He was with our 2000 IRA Con Kolkata with me, and he's a very nice person. He had spent a lot of time in Kuwait as well. Dr. Anupam Waklu, he was a professor and head of rheumatology, KGMU Lucknow, recently joined in Apollo Lucknow. So both of them will take care of today's 4 sessions. So may I request Dr. Uppal to start the proceedings.
Good evening, everyone. First, I wish to thank Dr. Alakendu Ghosh, President, Indian Rheumatology Association, for the opportunity to moderate this webinar series. Our first speaker is Professor Vikas Agarwal. He is professor in the Department of Clinical Immunology and Rheumatology at SGPGI Lucknow. He will be talking on musculoskeletal sarcoidosis. His talk will be followed by a 10-minute question and answer session. Kindly put your questions in the question and answer section at the bottom of your screen and not in the chat section, and kindly keep your mics muted. Over to Professor Vikas Agarwal.
Very good evening to all of you, and I thank Professor Alakendu Ghosh and Dr. Sapan Pandya for the invitation. And musculoskeletal sarcoidosis is one disease which is uncommonly seen in rheumatology OPDs, but many times it has foxed us and has led to grave errors also when the disease is actually a very much treatable condition. So as we know that sarcoidosis is a chronic inflammatory multisystem granulomatous disease of unknown etiology, and it primarily affects lungs, lymph nodes, eyes, skin, and liver. But a considerable proportion of patients do have musculoskeletal manifestations. The annual incidence of the disease is very variable across the world. It's high in Scandinavia and in African Black Americans, and is supposed to be very infrequent in Asian countries. Lung is the most common organ which is involved in more than 90% of the cases of sarcoidosis. But because of its diverse manifestations, it can pose diagnostic and management challenges for even the most astute clinicians. In the table on the left side, it can be seen that so many differential diagnoses has been listed before you come to a conclusion of a diagnosis of sarcoidosis, because there is no direct test to confirm the diagnosis of sarcoidosis. So many times it becomes really difficult. There are diagnostic criteria which has been proposed in form of non-caseating granulomas on tissue biopsy, which demonstrate classically lack of any acid-fast bacilli on biopsy or on culture, along with certain minor criteria which has been listed here. So many times it is the clinician's judicious judgment about the diagnosis which is required to come to a conclusive diagnosis and appropriate treatment. There are reports that when the diagnosis cannot be made by tissue biopsies, then bowel fluid analysis can help. And a triad of a ratio of CD4 to CD8 of more than 2 or 1% or less of neutrophils or 1% or less of eosinophils has a good sensitivity and positive predictive value to diagnose sarcoidosis and to differentiate it from other conditions. It is almost as good as a transbronchial lung biopsy. So coming on to the main topic for today's discussion, that is the musculoskeletal manifestations. Very often it can present with like non-specific arthralgias or acute onset arthritis in form of ankle involvement along with erythema nodosum and evidence of asymptomatic hilar lymphadenopathy, which we all know as Lofgren syndrome. Rarely or uncommonly, it can present with symmetric inflammatory chronic polyarthritis, which exactly mimics like rheumatoid arthritis at times and is difficult to diagnose. Or it can present Jacquard's-like arthropathy, which is classically seen in lupus, but can also be seen or has been reported in patients with sarcoidosis. Axial disease can be a presenting manifestation and has been reported in small case series and various case reports. Other manifestations which has been reported are dactylitis and enthesitis, and very uncommonly, patients may present with myositis. We are very well aware that sarcoid granulomas can involve the bone and can present with various bony involvement, which may vary from asymptomatic to painful bony lesions. So coming on to the acute arthritis, that is Lofgren, as has been shown in the diagram, asymptomatic hilar lymphadenopathy in association with erythema nodosum and ankle arthritis or periarthritis is a classical triad. It is the most frequent musculoskeletal manifestation. It has got a seasonal clustering, and especially during the springtime, and this has come most from the northern hemisphere. Patients of Lofgren who had HLA-DR-B1 O3 positivity, they usually have a very good prognosis. Either the disease is self-limiting, resolves completely, or they have excellent response to NSAIDs. Ankle joint involvement is usually periarticular, not articular. As you look at by an ultrasound imaging, you won't see any Doppler sign in the joint, or you will hardly see any fluid in the joint. It may be associated with constitutional symptoms like fever or weight loss. The natural course of Lofgren syndrome is generally it tends to resolve completely, either spontaneously or on treatment. However, if you see a patient with erythema nodosum or ankle arthritis and hilar lymphadenopathy with respiratory symptoms, then these patients are likely to have some other disease which is mimicking like Lofgren syndrome, and one need to carefully evaluate these patients for infection like tuberculosis, cryptococcosis, or coccidioidomycosis, or histoplasmosis, depending on the scenario in which patient is presented. Chronic arthritis is uncommon, and it can occur with other extrapulmonary manifestations. And generally, these extrapulmonary manifestations are in form of cutaneous involvement, where you have nodular or plaque-like lesions. Typically, joint involvement is symmetric, and it usually involves medium to large joint or even small joints of hands, which can mimic like rheumatoid arthritis. Destructive arthritis is very uncommonly described. Synovial fluid examination may not yield any help, but biopsy can show granulomatous lesions, and it can also help in exclusion of other diagnoses like infections, which we always suspect, especially in country like ours. Jacquard's arthropathy is characterized by deforming but non-erosive arthritis, and it, its presentation in sarcoidosis is actually seen in context of extensive internal organ involvement, which may follow the Jacquard's arthritis. And if we do a biopsy, we can demonstrate that there is evidence of fibrosis or presence of granulomas with epithelioid cells in the muscles and the tendon sheets. Spine involvement is often asymptomatic, so we don't know the exact prevalence of this presentation of sarcoidosis. They are generally picked up incidentally when patients are undergoing imaging for any other purpose. They may appear lytic, sclerotic, or both. So sometimes they can mimic like a metastatic disease. Sacroiliitis has also been reported in sarcoidosis in several case reports. Generally, it is unilateral, and the diagnosis can be confirmed by biopsy, which can show granulomas. But in a country like ours, where tuberculosis is endemic, a unilateral sacroiliitis with a granulomatous lesion on biopsy is almost always treated like tuberculosis first, and only later on we can, unless patient has some characteristic extra pulmonary or extra articular manifestations of sarcoidosis, it's difficult to make a diagnosis of sarcoidosis. Dactylitis is usually associated with chronic systemic involvement, and it has been described in coexistence with lupus pernio and other forms of cutaneous sarcoidosis. So if you are suspecting sarcoid dactylitis, look carefully at the skin, and if you find some evidence, maybe a biopsy can confirm a diagnosis. Generally, dactylitis is symmetrical, and it generally affects second and third phalanges, whereas the metacarpophalangeal joints are preserved, as you can see in the X-ray, which is being put up on this very slide. Histology can confirm tenosynovitis and soft tissue granulomas. Again, this can be confirmatory for a diagnosis of sarcoidosis. Radiographs can give a very good idea, as has been shown in this classical radiograph, that there could be cystic lesions and a characteristic lattice-like appearance, which can be seen in the fourth phalanx, proximal phalanx of this radiograph. Joint line erosions are not characteristically seen with sarcoid dactylitis. Now coming on to another very important organ which is often missed out, that is muscle. There are three distinct clinical patterns of muscular involvement in sarcoid. Typically is chronic myopathy, whereas uncommonly it can be nodular myopathy, and very rarely we can have acute myopathy. So skeletal muscle involvement, asymptomatic, if we start doing biopsies in all the sarcoid patients, can be seen in almost 50% of all sarcoid patients. But symptoms are seen in less than 3% of these. And typical symptoms are generalized weakness, fatigue, and reduced exercise capacity. So I've just given a brief introduction about the chronic myopathy. This is the most common form of muscle involvement in sarcoid, typically seen in females between the ages of 50 to 60 years. The disease progresses with an insidious onset and is progressive, generally involves symmetrical proximal muscle weaknesses, and may involve trunk and the neck muscles, mimicking exactly like polymyositis. Patients may have normal levels of muscle enzymes, but if you do a EMG, it will reveal a myopathic pattern of EMG, which might be suggestive of that patient has got inflammatory myopathy. And muscle biopsy typically shows granulomatous change along with infiltration of various immune cells in the perimycial and the endomycial region. However, very recently, fluorodeoxyglucose PET-CT scan has emerged as a very sensitive imaging technique for detection of muscle involvement in sarcoidosis. As can be seen in this very diagram, it's a tiger man uptake pattern which is being seen here. So this pattern is very characteristic, and it actually helps you in localizing the site of the muscle biopsy. The other uncommon form of sarcoid muscle involvement is a nodular sarcoid myopathy, which is characterized by single or multiple nodules in the muscles. And generally, these are also symmetrical. Nodules are often painful and can lead to development of contractures. Typically, muscle enzymes and even EMG are normal. However, histological analysis of the muscle can show that there are lesions or there are granulomas which are in between the muscle bundles. MRI can help in localizing these pattern of myopathy, as has been shown in this particular slide MRI picture, which is showing muscle involvement, and typically it is showing that on T2 weighted images there is a increased signal, and it is mimicking like a tumor. Acute myopathy is least common, and however it occurs in early phase of or early course of sarcoid, and typically happens in patients of less than 40 years of age. And its presentation is comparable to any other inflammatory myopathy with rapid onset of proximal muscle weakness and myalgias associated with increased levels of muscle enzymes. Muscle biopsy will typically reveal non-caseating granulomas with lymphocytic infiltration. Bone involvement is usually asymptomatic and is often detected incidentally. Its prevalence or its report has varied uh, depending on the series from where it has been reported. However, estimated prevalence varies from 1 to 15% in all the patients of sarcoidosis. And three patterns of bone involvement are reported. First one is a permeative or moth-eaten appearance, which involve the cortex of the phalanges and are accompanied by soft tissue swelling. The other ones are lytic lesions, or also called as bone cyst, as I had shown in the previous radiograph, which appear as cortical defects in the phalangeal heads or round punched out lesions. And very uncommonly or rarely, these could be sclerotic lesions, which are generally seen in spine. Bone involvement is most frequent in the proximal and the middle phalanges. However, it can involve almost all the bones, including the bones of the skull, nasal bones, maxilla, sternum, ribs, vertebra, pelvis, tibia, and femur. One point to note here is that serum calcium and alkaline phosphatase levels are typically normal despite multiple lesions in multiple bones. However, one need to be very cautious that whenever you see a patient of sarcoid with bone involvement, please look for other multi-system involvement, because it is likely that this patient is having other organ system involvement as well. And this is a classical radiograph which I have taken from Google Images to demonstrate various changes of the bone, which I have highlighted in my presentation. So the pathology is, we all know, is a classical, discrete, well-formed, non-caseating granuloma, which is the hallmark of sarcoidosis. And lesions often appear in cluster of epithelioid cells and multinucleated histiocytes. It may be accompanied by a sort of a rim of inflammatory cells, followed by a rim of fibroblasts. A brief word about pathogenesis of sarcoidosis. We all know that in genetically predisposed individuals, some environmental agent, be it an infectious agent or some kind of an organic material or an inorganic compound, which causes activation of the antigen presenting cell, that is the dendritic cell. And these dendritic cells, when they move to the nearby lymph nodes, they activate T cells. And these T cells actually develop into a Th1 phenotype, which secrete a lot of gamma interferon. And this leads to further activation of the macrophages and the dendritic cells, causes more release of TNF alpha and interferon gamma, leading to formation of granuloma. Once this active phase is subsiding, then the switch over from Th1 to Th2 type happens. And now a lot of pro-inflammatory cytokines are being secreted, which favors fibrosis and leads to resolution of the activity. So this was the concept. This image has been taken from New England Journal review article published in 2007. However, in last say around 7-8 years, it has been observed that another very important source of gamma interferon is a Th17 cell. Now these Th17 cells, which secrete a lot of interferon gamma, they are also called as pathogenic Th17 cells or Th17.1 cells. Now, so these Th17 cells are inherently not very sensitive to glucocorticoids, or even they are suppressive, they are not suppressed by T regulatory cells. And the explanation for this non-suppression of or poor functioning of T regulatory cells in sarcoidosis, which has been reported in a number of studies in bowel fluid as well as in the peripheral blood, comes from the fact that Th17 cells generally are not suppressed by CD8 positive T cells. And when IL-17 is given to either Th1 or other T cell subsets, they also become sort of resistant to suppression by T regulatory cells. We don't know the exact mechanism, but this is what is being reported, and this was reported last year in October in PNAS. So this group is working in this area, why the or how Th17 cells or IL-17 is causing resistance to suppressive effect of T regulatory cells. I'll briefly share data from one of our study, which we published as a multicentric study in 2018. And so here we could actually enroll some 117 patients. 88 patients had acute sarcoid arthritis, whereas 29 had chronic sarcoid arthritis. And as can be seen, that acute sarcoid arthritis is more common, and it involves frequently ankle, knee, and the wrist joints. However, most of the time, the acute sarcoid arthritis is self-limiting, whereas chronic sarcoid arthritis is generally polyarticular and it involves PIP, metacarpophalangeal wrist and shoulder joint, which were more frequently seen as compared to acute arthritis. Also, we were able to demonstrate a lot of peripheral lymphadenopathy and uveitis in patients with chronic sarcoid arthritis as compared to the acute one. So if we carefully examine the patient, probably we can detect patients who are likely to become or likely to go into a chronic arthritic phase. So this is the data which we compare in our study with the other studies which have a good number of acute arthritis patients. So our results were almost similar. And like others, we also reported that most of our patients had a very good response to non-steroidal anti-inflammatory drugs. Very few patients required low-dose glucocorticoids or other agents like hydroxychloroquine. And when we look at the data of chronic arthritis series, we could see that in other reported data, patients with chronic arthritis were not having a good response to non-steroidal anti-inflammatory drugs or methotrexate or other immunosuppressive agents. However, in our series, out of 29, we had a follow-up data of 16, and of these 16, 12 were in complete remission, and 4 actually were in partial remission. And most of these patients were actually getting NSAID, glucocorticoids, methotrexate or hydroxychloroquine or azathioprine. However, in a country like ours, one has to be very careful in making a diagnosis of sarcoidosis because we are taught with a concept that tuberculosis is generally monoarticular, which may not be the case. And this data, which has been reported from our own center of 50 plus tuberculosis arthritis patients, a good number of patients has got oligoarticular presentation. So one has to be rather keeping in mind that tuberculosis can also present like oligoarticular disease, and it can also have the similar kind of joint involvement as sarcoidosis is having. Another important point to note about tuberculosis is we need not forget about Ponsett arthritis, which is a type of a hypersensitivity to antigens of Mycobacterium tuberculosis elsewhere in the body, not in the joint. And this very elegant study, which is published from PGI Chandigarh by Aman Sharma's group, has very categorically pointed out. And if you look at the pattern of the joint involvement, you can see that it's very difficult to differentiate Ponsett arthritis from sarcoid arthritis. So they had elegantly in this particular paper has proposed criteria for diagnosing Ponsett arthritis, and which I actually should point out that all of us should be aware of these diagnostic or these criteria which they have proposed for diagnosing Ponsett arthritis. Now, quickly coming on to the treatment of the musculoskeletal sarcoidosis, NSAIDs remain the mainstay of treatment in acute arthritis, and generally, most of the patients will actually have a very good response. And it is ineffective in chronic arthritis or vertebral sarcoidosis, so it should not be used for a long period of time. And those who do not respond to NSAIDs, they should be quickly switch over to steroids or other agents. Steroids, this is a very common agent to be used in both acute and chronic sarcoid arthritis after NSAIDs. But usually it is used in a low dose. 10 to 20 milligram is sufficient, which should be tapered quickly over a period of 4 to 6 weeks. And however, the response in chronic arthritis is very variable. Intraarticular steroids or intramuscular steroids can also be used. And it has been reported from in the literature that a dose of more than 20 milligram generally is not beneficial in chronic arthritis cases. There are some pointers towards predictors of chronicity: a black race, involvement of shoulder, wrist, MCP, PIP, and knee joint, or a presence of peripheral lymphadenopathy or lupus pernio and uveitis, which actually sort of is a forerunner or is telling you that this patient is likely to land up with a chronic sarcoid condition. So one has to be prepared right from the beginning in treatment of these cases. So once patient has not even responded to steroids, then what are we left with? We are left with disease modifying drugs. And out of disease modifying drugs, all of us have the best experience with methotrexate. But people have also used leflunomide and has reported a good effect of leflunomide, and other like azathioprine has been also used. Methotrexate reduces the dose of steroid even in recalcitrant or difficult to treat musculoskeletal manifestations of sarcoidosis. And even if, God forbid, there is a failure of disease modifying drug, then we are left with no choice but biologicals. And TNF inhibitors are the drug of choice here. And it has been reported that most of the experience is actually with infliximab. So generally it does work. However, in only one study looking at something around 16 patients, I think this is a study from US, they didn't find much of an effect of infliximab in the joint symptoms of patient with sarcoid arthritis, whereas the other extrapulmonary manifestations actually improved. And there is one case report where it has been reported that adalimumab has shown some beneficial effect in patient who has failed on infliximab. There is some data on the usage of rituximab, especially for extra-articular manifestations, including neurological, cardiac, pulmonary, and even cutaneous involvement. However, there is no evidence to suggest that rituximab may be beneficial in patients with sarcoid arthritis. There are, however, reports where people have reported development of Lofgren-like presentation following rituximab therapy in patients with other autoimmune diseases. So one has to be very careful in usage of rituximab in patients with sarcoidosis. For bone sarcoid, treatment usually includes either you don't treat, or if patient is symptomatic or there are other manifestations, then you treat with steroid along with disease modifying drugs, and if necessary, then maybe anti-TNF or surgical intervention can be called for. For vertebral lesions, glucocorticoids, hydroxychloroquine, and TNF inhibitors have been used, with some studies showing partial response and other studies reporting excellent response. Duration of therapy in acute cases is very easy to define because generally condition is short lasting, self-limiting, or resolves quickly following treatment. So I think the best strategy is to treat as per the symptoms because there are no guidelines. However, in chronic cases, treatment up to 6 to 12 months of remission should be planned because otherwise these patients are likely to relapse. However, there are no guidelines and one has to make a shared decision with the patient how long to give immunosuppressive regimen or glucocorticoids. Prognosis of acute arthritis is very good because most of the patients, they go into remission quickly and very infrequently they relapse. However, the long-term prognosis is actually more dependent on extra-articular features. And patients who have got erosive disease or Jacquard's arthropathy, which are seen in cases with advanced or chronic sarcoid arthritis, they can require long-term treatment. However, still the prognosis is likely to be good. So the take-home message from my presentation today is that acute arthritis in sarcoid is often self-limiting and responds to non-steroidal anti-inflammatory drugs, and they have a very good response within few weeks to few months. Whereas management of chronic arthritis is dependent on steroid and other agents like methotrexate, or maybe there is a need for TNF inhibitors. In refractory cases, obviously TNF inhibitors can be used, and treatment is more commonly, the duration of the treatment and the intensity of treatment is more commonly determined by the presence of other extra-articular manifestations as well. Lastly, I would like to acknowledge my colleague, Professor Dr. Durga Prasanna Mishra, who is Associate Professor in our department, and Dr. Avinash Jain, who is an Assistant Professor at SMS Jaipur, and Harshit Singh, who is my PhD and has now passed out in preparation of this particular presentation. And we are working on many aspects of sarcoidosis, including T cell signature and also differentiation of sarcoid with TB by use of metabolomics. But I didn't share much of the data because it's not published. And with this, I will conclude my session, and I'd like to have any comments or questions or suggestions from the audience. Thank you.
Thank you, Professor Agarwal, for that brilliant talk. We have a couple of questions. The first one is, how common is extrapulmonary sarcoidosis in the absence of hilar lymphadenopathy and pulmonary involvement?
Very good question. If we exclude the asymptomatic hilar lymphadenopathy, like I'm more concerned about the interstitial lung disease part. So we do see many patients who present typically with articular manifestations and without any symptomatic pulmonary disease whatsoever. In fact, in our series of 117 patients, I think only 30 to 35% patients were having pulmonary manifestations. Otherwise, two-thirds patients were not having any kind of a pulmonary manifestation. So if you go for imaging by CT scan or other modalities, one may find that they are involved. But whether they require any form of intervention in form of treatment, actually we were not actually treating our patients with even with asymptomatic involvement in the lungs with any kind of immunosuppression.
Okay, thank you. Is a negative MON2 or quantiferon TB gold good enough to differentiate between sarcoid bone involvement versus tubercular bone pathology?
Not at all, because you need to demonstrate granulomas, and also one need to look for any presence of acid-fast bacilli, whether on staining or on culture. Because many times we have seen even patients who have got extensive tuberculosis, the MAN2 test may be negative, and interferon gold assay may not be available at all the labs and at all the centers.
All right, all right. There's another point. How do we differentiate between, let us say, seronegative rheumatoid and chronic sarcoid arthritis? Because the manifestations, treatment, everything seems to be quite similar.
Yeah, difficult question. And so one need to be just aware of the sort of the bone involvement in sarcoidosis and the joint involvement in rheumatoid arthritis. If we carefully look at the inflammation in sarcoid, suppose we do a ultrasound imaging of the sarcoid arthritis joints, most of these patients will show actually some kind of a swelling either in the bone or in the soft tissue. but not in the joint. Whereas in rheumatoid, we do see a lot of joint involvement in form of fluid and power Doppler signal in the joint. Also, the erosions are typical for rheumatoid arthritis, whereas erosions are very, very uncommon in sarcoid arthritis, even with chronic sarcoid arthritis. So it is more of a cystic changes, and if you see more of a lattice-like presentation that I have shown, this is very characteristic for a diagnosis of sarcoidosis, and hardly one will see such a change in rheumatoid bone. But I
And,
agree, many times it is very difficult to make a diagnosis just on the basis of the joint involvement alone. One has to look carefully for the other organ system involvement, like
uh,
skin and the lungs, and maybe
okay.
hepatosplenomegaly or lymphadenopathy, which can help in making a diagnosis.
Somebody wants to know, can serum ACE help in this situation?
Not at all. Good question. I didn't cover it up because the sensitivity and the specificity of serum ACE level, even in monitoring the disease in patients who had a high serum ACE level at the beginning, not everyone will have a serum high ACE level in the beginning. It is not at all diagnostic. That is number one. It is non-specific, and any disease which involve the lung parenchyma can also lead to rise in serum ACE levels. And yet nowadays there are papers which are available even in pulmonary literature, which says that it is not a good idea to follow a patient with only on the basis of serum ACE level to make out something about the disease activity of the patients.
All right. Thank you so much, Professor Vikas Agarwal. Unfortunately, we don't have time for more questions. I would like to introduce our next speaker now. He is Professor Abel Lawrence. Again, he is a professor in the Department of Clinical Immunology and Rheumatology at the SGPGI Lucknow. And his topic is immunology, a very hot topic, immunology of COVID vaccines. And as usual, kindly put your questions in the question and answer section at the bottom of your screens. Over to you, Dr. Abel Lawrence.
See, we have been having vaccine for so many decades. Vaccines have changed human history. Vaccines have changed healthcare. But no time before this has humanity faced a challenge like this coronavirus vaccine. And thanks to the vaccine research, for HIV, which never succeeded. In fact, immunology received large amounts of funding for HIV vaccines, but we never got an HIV vaccine. Probably we never needed an HIV vaccine because it is much easier to stop. But that has led to a record, success in the case of COVID. Normally it takes 5 to 10 years for vaccine development, but we got a vaccine under 1 year. In fact, in April, I had said that we might have a vaccine at the earliest by October, and that came true. So this was because vaccine research did not start with this pandemic. Vaccine for a coronavirus was under development for the last 10 years. So this is something we should realize, because people had anticipated coronavirus pandemic. The general research on coronavirus vaccine were going on for a long time, and that is why this happened. So, and we have a multitude of vaccines of all kinds available for coronavirus this time. From traditional, actually, in fact, none of the vaccines are actually traditional. All the vaccines for this COVID are actually related non-traditional and new types of vaccines. The reason being that most of the time we develop vaccines against viruses against which good protective natural immunity exists. We know that the natural immunity after COVID infection is far from adequate. Therefore, simple methods of vaccine development do not work, and we literally have to hack the immune system. That is, we need to tinker with the immune system and trick our immune system into developing a better vaccine than natural infection. So, we already have several types of vaccines which are approved or near approval, which include the completely new mRNA vaccines. And these mRNA vaccines were under development since around 2004 in experimental animals, and now it has become real. Then viral vector vaccines, which are like Oxford and Janssen vaccine, which should be seen as DNA vaccines, which use a viruses as vectors for DNA delivery. That's the best way of seeing them, because they are non-replicating vaccines. These viruses do not replicate; they just deliver the DNA payload into the body. And all of them use adenovirus, and which brings in some advantages and some challenges. Then relatively traditional protein subunit vaccine Novavax is nearing approval, and all these different vaccines have advantages and challenges, and it will be understanding the immunology will help us decide which one would be appropriate. So let's get into the life cycle of this virus. This virus uses, primarily uses ACE2 as a receptor, but it can use additional receptors like neuropilin. So the thing is that all coronavirus generally have two receptors, and this spike protein has two ends, two domains, and each domain separately binds to two different receptors. This allows this virus to switch receptor usage. So this is important in host switching. Coronaviruses are notorious from jumping from one species to another, and this is because it need to bind only one of the sites for infecting the thing. So if ACE2 doesn't fit, it can use neuropilin, and so this is and these two domains of the spike protein can evolve separately. So this makes it possible for virus to so there is no way to completely stop this virus, even neutralizing antibody, everything. So this is a very evolutionarily robust virus. And what happens once it infects? This is an RNA virus, and the replication of this virus takes place in the cytoplasm. And once the virus enters, the first thing the virus does is replicate its genome, make multiple copies of the genome, and for that it needs a replicase complex to be expressed. And after the replicase complex is expressed, subsequently other accessory proteins are expressed, and these accessory proteins actually majority of them target the immune system. In fact, more than a dozen proteins, open reading frames, have been identified which have multiple immunomodulatory properties, and these allow the virus to evade the immune system in multiple ways. And then subsequently, towards the end, the spike protein and the structural proteins necessary for actual replication and formation of the virion proteins. This is very relevant, because when we are developing vaccines against a spike protein, this virus may, in the earlier phases, may evade the immune system, and ideally an immune response against the early expressing replicase also may be useful. And this is because after that stage, the virus has mechanisms to evade. And as I said before, there are multiple pathways for viral sensing, from RIG helicases to, in fact, most of the pathways, there are proteins which target almost every pathway for innate viral sensing, including NDF, everything. So this is why once the SARS-CoV-2 infects the cell, there is very little interferon production. In fact, the most remarkable thing is that interferon response genes are not expressed in the initial stages, and paradoxically, we have a inflammatory cytokine production of IL-1, IL-6, etc. But eventually interferon gets activated. But by the time the innate immune system recognizes the virus, the mRNA content, viral mRNA content of the cell is close to 50% of total mRNA or more. So basically, there is a delayed innate immune system sensing by the virus. This allows the virus, that is why the incubation period of SARS-CoV-2 is longer than most such RNA viruses. Beyond this, there is additional adaptive mechanisms which let the virus evade the immune system. So most importantly, the virus has two proteases, the C3-like protease and the papain-like protease. This papain-like protease has got de-ubiquitination capability. You know, from immunology, you would know that ubiquitination is the process by which proteins and organelles are tagged with ubiquitin, and these ubiquitinated proteins are degraded in the proteasome. So why this ubiquitin is important? And previously it was believed that antibodies protect from viral infection by blocking the entry of the viruses. It happens to some extent, provided if it precisely blocks the receptor binding domain. But most of the antibodies cannot do that, and many viruses end up, at least some of the virus end up entering the cell even despite the presence of blocking antibodies. So what has been shown is that in many viruses, even if viruses manage to enter the cell, when it does not cause productive infection if the virus is coated with antibody. The reason for this was not clear until a few years ago, and the understanding came from failure of basically adenovirus were used as vectors for gene therapy, and it was found that people who have antibodies to adenovirus, the gene therapy failed. That is because when antibody-coated viruses enter the cell, there is a FC receptor in the cytoplasm. In fact, the FC receptor with the highest affinity to antibody FC component is actually the TRIM21. And you might remember TRIM21 is nothing but Rho52. And this Rho52 TRIM21 senses this immunoglobulin when the virus enters the cytoplasm and attaches an ubiquitin into it. And this ubiquitin, virus gets degraded into the proteasome directly before it can do anything else to the cell. So this is the primary mechanism of antibody-mediated intracellular virus neutralization. This is not in immunology textbooks. This is a recently discovered mechanism which is only known for a few years. And this is very important for enteroviruses and adenoviruses. Many of the other viruses actually have evasion mechanisms against this. That is why if you have evasion mechanism against this, the antibody-mediated protection will only be partial. So this, if you know this, you'll realize that while antibodies will prevent infection to some extent, it will not be 100% sterilizing. And this has been drawn out by the clinical trials. The question that remains is how much of this is, now we know that Novavax, which is a predominantly antibody-mediated dependent vaccine, has 95% protection, shows that antibodies still do a lot. And why we know this is important? Because the infectivity threshold of cells in the presence of antibody-coated virus is determined by the amount of TRIM21 present in the cell. So if TRIM21 is knocked out, antibodies cannot prevent a viral infection. So this is why this is the rate limiting protein that determines the threshold for infectivity of the virus, and this coronavirus can trick that. Now let's come to the major effective mechanisms against viruses. So when you induce a immune response either naturally or through a vaccine, you need to activate effective effector mechanism. The primary mechanism of protection against a new infection is actually antibodies. This is borne out by the fact that those with antibody defects, they can get recurrent infections to viruses which may actually have lifelong protection. For example, if you have antibody defects, you can get repeated attacks of chickenpox. But if you have your cell-mediated immunity is intact, your body will naturally clear it. So the cell-mediated immune response is important in clearing antibody-infected cells, but antibodies are the primary mechanism for the initial protection of the. So you need to produce good high-affinity blocking antibodies. So that is one goal. Second, you need, once the cells are, so as we know in this virus, antibodies will not completely block. So if you want to limit the infection, you need to clear antibody-infected cells, which is where the cell-mediated immune response comes in. And the most important cell which for clearing viral infection is actually CD8 cytotoxic cells. Why is this important? Because CD8 cytotoxic cells, T cells recognize the virus, that is viral peptides in the context of MHC class 1. And MHC class 1 is expressed in all cells, whereas MHC class 2 is expressed only on professional antigen presenting cells or other cells in the presence of interferon transactivator. So this is, you can induce this when there is a viral infection going on and interferon is active, other cells can also express MHC class 2, but primary mechanism of defense is CD8 cytotoxic. But if the CD8 cytotoxic cells fail to clear the viral infected cells, then CD4 cells come in, can see. There is a, CD4 has two functions. CD4 help is needed for the activation of CD8 cells and formation of antibodies. But CD4 cells also have cytotoxic effector functions, and that comes in late. And once that comes into play, pathology ensues, which is what we see in COVID. There's a lot of CD4 mediated immunopathology in COVID. And now there is a paper which shows that TH7, that is TH17 tissue resident memory cells are active in COVID in lung disease, and they continue to cause lung damage even after the virus is clear. So we do not want CD4 cells, see, CD4 cytotoxic cell good, but we don't want that. We want the virus to be cleared much before that. So an effective vaccine should produce good neutralizing antibodies to the receptor binding domain and also induce CD8 cytotoxic T cell response. And then another concern which was there in the development of COVID vaccine has been the fear of antibody dependent enhancement, which is something which was detected when in early relatively naive attempts at vaccine development for SARS and MERS was done. What was found was that when inactivated vaccines, inactivated COVID vaccines were given to animals, they developed eosinophilic pneumonia, as if there was a hypersensitivity pneumonitis and like a Th2 response. And this actually increased the pathology in vaccinated animals. So therefore, when vaccines were being developed, there was a concerted and attempt to induce a Th1 biased vaccine which avoids Th2 response. This is why this viral vector vaccines and mRNA vaccines were preferred, and inactivated or subunit vaccines were not pushed early on. There's another fact: inactivated subunit vaccines are much more difficult to manufacture compared to the other vaccines also. So then other mechanisms of antibody-dependent enhancement is that non-neutralizing antibodies can also induce complement activation and additional immunopathology related to this immune complex formation. So there are multiple mechanisms of antibody-dependent enhancement, and so this had to be avoided. Now, how do we induce desirable CD8 response? We know that there are two major pathways of antigen presentation, the cytosolic pathway and the endocytic pathway. Cytosolic pathway is basically cytosolic antigens, that is mainly antigens which are produced within the cell. They get degraded by proteosomes and then get loaded onto the MHC class 1 molecules and get presented. So whereas the endocytic pathway from lysosomes preferentially goes to the MHC class 2. So the endocytic pathway is important in presenting antigens CD4 T cells. So suppose if you inject protein antigens, they predominantly get presented as CD4 cells. This is also important for antibody production. Whereas when the protein is expressed within the cell, so the traditional way to get the antigen expressed within the cell was using a live attenuated vaccine. What is the problem with live attenuated vaccine? Developing a live attenuated vaccine takes time. Even if you actually magically produce a live attenuated vaccine, validating the safety of a live attenuated vaccine is very challenging, and there is no shortcut to it. which is why we have not seen any live attenuated vaccines for coronavirus. And rather, people prefer to go with non-devils, that is viral vector platforms inside the protein, and so that you know the basic safety of the vector, so you can go ahead and shorten the time development. So any vaccine which can produce, that is, which can synthesize the protein inside the cell, can induce a cytosolic or CD8 response. So naturally, this is not, there is pathways of cross presentation, but that is a research topic. That's not very easy to do. There is leakage between the two leading cross presentation, but this is the predominant method. Now, the biggest secret of immunologists, which nobody discussed until the turn of the 21st century, was adjuvants. That is, we all talk about, you inject an antigen, it does not produce a, adequate immune response. You need to put something else to it, which is called an adjuvant. Adjuvants perform their function by multiple ways. So the commonest adjuvant used in the run-of-the-mill vaccines, which produce an antibody response, is alum precipitation. Then this Novavax uses matrix M. Then, so what do these, basically what they do is what you need to do is you need adjuvants to activate the, innate immune system. The antigen has to be persistent, antigen persistence has to be increased, and multimeric, that is multi-epitope antigens, when they form aggregates, they induce immune response much better. Now there is a paper which shows that if polyvalent antigens, that is antigen structures, nanostructured antigens with multiple epitopes, can directly activate B cells and induce their proliferation. However, plasma cell differentiation still requires CD4. But these are, these methods, are actually good for B cell thing. But if you want a good CD8 T cell response, these alum and matrix M, all these are inadequate. And the best adjuvants we know that can stimulate a Th1 response is actually the TLR7 and 9 agonists. And that's why the DNA and RNA are themselves the best adjuvants for developing a good immune response. So if you use a DNA vaccine, whether DNA is delivered directly or a vector DNA vaccine such as adenovirus. So what's the problem with the vector why if the adenoviral vector is a DNA vaccine, what's the problem? The problem is that if you have antibodies to adenovirus, the previously mentioned TRIM21 mediated inactivation can take place, and that may make the decrease the immunogenicity of the vector. So this is the problem specific to adenovirus itself. So then we have our Covaxin, which uses there's a TLR7/8 agonist. Basically, it is something, a newer version of imiquimod. Imiquimod is a TLR7 agonist, and that's a potent Th1 adjuvant. So these adjuvants are the secret for producing good immune response, but they are also a potential problem. A lot of the adverse events of vaccines also come from adjuvants. Adjuvants stimulate immune response and can cause inflammation. And you must be aware that the studies of MI events in cities spike during pollution. Even something like a atmospheric vehicular pollution causes inflammation, which increases attacks of strokes and myocardial infarction. So something like a vaccine which stimulates immune response. Suppose if it cannot probably cause an atherosclerosis, but somebody who has an ongoing imminent thrombotic event may precipitate something. It's not something easy to prove, but large data set may show something, but this is possible because even pollution can cause them. Then you must be aware of adjuvant-induced arthritis model. So adjuvant can act as things which can stimulate immune response, and if some other autoimmune process is going on at the same time, it may precipitate something. So this is something we need to be worried about, and especially in relation to autoimmune diseases. And we know that imiquimod can cause subcutaneous lupus-like lesions in people who are treated with. Imiquimod is used for warts and other skin diseases. So these adjuvants are, we need further data, and it's very difficult to say anything other than speculate on that. Now, coming to the vaccines, now I already covered these things. These viral vector vaccines, like the Oxford vaccine is an adenovirus 5 vaccine, and adenovirus 5, the variability in response rate could be because of the antibodies to adenovirus. But they can be expected to produce CD8 response, and the antibody titers are comparable to natural infection, but less than the nucleic acid vaccine. And the nucleic acid vaccines, what they basically do is, as I said earlier, you want the antigen to be expressed in the cell. So instead of sending an antigen, you are just sending the message, the information needed to synthesize the antigen in the form of mRNA, and the mRNA expresses, is expressed inside the muscle and in other various cells, and then it gets presented. Again, there are two types of mRNA vaccines, the Pfizer vaccine and the Moderna vaccine. Both are non-replicating. They're basically just mRNA, which are chemically modified. The chemical modification decreases the immunogenicity. In fact, the problem, unlike other vaccines, the problem with mRNA was too much inflammation. In fact, when people first experimented by injecting mRNA, there was significant immunological adverse effects. So this also is a clue that we need to be cautious about this. So chemical modification of mRNA decreases the immunogenicity and increases stability. mRNA in the beginning, in fact, in the beginning, I was used to be skeptical because the stability of mRNA was an issue. In fact, these chemical modifications and nanostructure, and then they are packaged in polyethylene glycol nanoparticles. So this leads to increased stability. In fact, there is another besides there is another company called CureVac, which claims that they have optimized the chemical modification such a level it can be, their vaccine can actually be kept in a regular refrigerator. So mRNA vaccines can improve. Then there is another type of mRNA vaccine called replicating mRNA vaccine. So in a replicating mRNA vaccine, besides the antigen, there is also the RNA-dependent RNA polymerase (RDRP) enzyme. So the RDRP gets expressed and the mRNA gets copied, so that it can reduce the dose of the vaccine required, and there is amplification of the mRNA inside the host. So while this has its advantages, it also may raise additional safety concerns, which is why the first replicating mRNA vaccine is more than 15 years old in animals, but we haven't actually seen anything until this coronavirus. And even an Indian company is actually making a replicating mRNA vaccine. In fact, most of the literature have been about replicating vaccines because probably they are more scientific interest. And then the Novavax uses matrix M adjuvant. We don't know what matrix M adjuvant actually is. Then we have the inactivated whole virus Covaxin, which uses imiquimod. And the problem with such an approach, they have, as I mentioned earlier, previous attempts at whole virus inactive vaccine led to Th2 response and hypersensitivity reactions. But Covaxin uses a novel adjuvant imiquimod. So this is perhaps the first time a TLR7 agonist is being used as an adjuvant in humans. So if it succeeds, it could be a revolution with it. But still, there are question marks because in the immunogenicity data they showed only 4 of the subjects had CD8 response, and well, that is not consistent. So let the data come out and we will be able to. Then everybody knows about the different phases of vaccines. in vaccine research, phase 3 trials are very important. Why? Because we are giving vaccines to normal people. So if you have something like a serious life-threatening disease, maybe perhaps even COVID, some level of adverse events are accepted. So what level of adverse events are accepted? When you treat a patient, what is in key comparator is case fatality rate. That is what percentage of patients admitted or people diagnosed with the disease may end up dying. For example, the case fatality rate of COVID is about 3%. Whereas when you give vaccine to a normal person, key comparator is actually infection fatality rate, which should include all asymptomatic infections. The infection fatality rate, nobody knows the final figure, but the upper limit of that could be about, it could be approximately 0.35%, which you can estimate from the population level mortality rate of the most affected parts like New Jersey, Belgium, etc. We get around 0.35%. So it cannot be lower than that. So when you look at it, what you really want is a vaccine which has mortality rate which is at least 1,000 times less than that of an infection. And if you want that, you need to do very large tests. Suppose there is an adverse event which happens in 1 in 10,000 people, we need to know that. This is why phase 3 trials are conducted with 30,000-40,000 subjects. Even then, extremely rare adverse events such as autoimmunity, etc., may not be shown even in these trials because most people enrolled in clinical trials are otherwise healthy people and people with serious comorbidities on immunosuppression or autoimmune disease which are relevant to us will not be included in these. And therefore, all vaccines need continued phase 4 studies and follow-up to study the adverse event. So phase 2 data showing efficacy is not sufficient. And big question that everyone asks is, would vaccine-induced immunity be better than natural immunity? This is generally, it used to be a dictum that natural immunity is better than, but that is not true in this case. In fact,
Dr. Lawrence, can you wind up?
Only 2 more. This is the second last slide.
Thank you.
2 more slides. So the thing is that coronavirus, as I said, has multiple immunomodulatory capabilities. It inhibits the follicular helper T cells in the germinal centers. So if you take COVID lymph node, there are no germinal centers. And because there are no germinal centers, that is why long-lived plasma cells are not produced. And in the absence of long-lived plasma cells, short-lived plasma blasts and the short-lived plasma cells survive only for a few months. That is where the antibody response wanes in a few months. So there definitely, this is not be applicable to the vaccine. So we can expect vaccine with a booster dose to outlast the immune response of a natural infection. So that is why people who have had COVID, they are also advised to take the vaccine. In fact, in the case of mRNA vaccine, a single dose may be sufficient for people who have previously had COVID. We don't have such data for the other Oxford vaccine which is available. And then autoimmunity risk. There are one sporadic case, we cannot say much. I am only touching upon the things which have been frequently reported. The anaphylactic reactions have been a common adverse event for both Moderna and the Pfizer mRNA vaccines, and they are being linked to the use of polyethylene glycol as part of the nanoparticles. Both use polyethylene glycol. In fact, polyethylene glycol is the only, other than the mRNA, polyethylene glycol is the only common factor between the Moderna and the Pfizer vaccines, and this is believed to be the culprit. And then there have been large reports of radio ITPs in patients who have received mRNA vaccines. And in fact, the New York Times had compiled some 1,300 either a few weeks, some time ago. So, and again, there are reports. There are also, I came across reports of ITP in people who have received other PEG-related products. So polyethylene glycol, we don't know yet, but polyethylene glycol may also be the culprit for idiopathic thrombocytopenic purpura. And then there were reports of demyelination. In fact, demyelination has been reported even with traditional vaccines like hepatitis B, and subsequently it has shown that those who had this demyelination either had multiple sclerosis before or eventually developed. So basically, those who are at risk of developing multiple sclerosis, you know, to develop an autoimmunity, you need to have a certain diathesis, you have to have a particular, MHC, and you need to have particular, other risk factors. If you are at risk of, so if somebody impending to develop an autoimmune disease may develop. So this is something to be looked, needs much more data in this thing. And there have been reports of arthritis flares, and you know that adjuvant-induced arthritis is a very well-known model for arthritis, and in fact, a good model for rheumatoid arthritis, maybe a better model than collagen-induced arthritis. And we know that autoimmune diseases do not occur suddenly. There are multiple stages. There needs to be breakage of tolerance, and then you need to have there must be some inflammation in the target organ for the autoreactive T cells or to home in non-looking. So maybe presence of systemic inflammation and adjuvants may just precipitate what is already in the pipeline. Then where are we going from here? So how does this end? How does this coronavirus end? The best way to look at it is look at other coronaviruses there are, and of which these, if you look at the so-called human coronaviruses, they exist in a kind of equilibrium. They exist by transmission between humans with seasonal variations, and there is no lifelong immunity. If you have had prior coronaviral infection, you have milder. You have most of the time you have upper respiratory infection. That doesn't mean that LRTI do not occur. Probably in non-immune individuals and in elderly, serious LRTI occurs. And in fact, during outbreaks in non-immune individuals, the mortality of some of these coronaviruses actually have been higher than the SARS-CoV-2. In fact, OC43 outbreak led to death in 8 out of 98 subjects, which is quite comparable to SARS actually. So essentially, what we are seeing is, I would say that if you look at it, our SARS is a much milder than the so-called human coronavirus. So essentially what we are seeing is an outbreak in a non-immune population. Once the population gets immune, the mortality rates may be lower, and we may have, it may become endemic. And there's a very good example of this. This OC43 itself is now believed to have entered human populations as recently as 1890. That is, this is derived from the bovine coronavirus, which is the most common cause of bovine pneumonia. It's an important cause of bovine pneumonia. And this bovine coronavirus, from genome sequencing, it has been timed. It crossed in humans 1890. There was also a flu pandemic of 1890. The thing is that we don't have samples to confirm that flu pandemic, and nobody knew about even viruses. In fact, in the 1918 flu was attributed to bacteria. Nobody knew about viruses at the time. So the 1890 flu pandemic might have been this bovine coronavirus gemmed, and then subsequently became human coronavirus OC43. So we are going to live with this COVID for a long time and expect to get boost, especially those who are at high risk may need booster doses. Eventually, when most newborn children get COVID, SARS-CoV-2 at a younger age group, and then they become immune, this virus and may not become clinically that very common and become sporadic like other.
Thank you, Dr. Abel Lawrence. That was quite a lesson in immunology. Unfortunately, we have no time for the answers and questions. So I request you to answer in the question and answer box. And thank you so much. And I will now hand over to Dr. Anupam Waklu, who will moderate the last two speakers. Thank you very much.
Thank you, Dr. Uppal. Good evening, everybody. Our next speaker would be Dr. Sumantro Mondal. He is Assistant Professor in the Department of Rheumatology at IPGMER and SSKM Hospital, Kolkata. And his topic today would be psoriatic arthritis. What would you target? IL-17 or TNF-alpha. Huge practical relevance. Over to you, Dr. Mondal.
So is my slide is visible and the pointer is visible also?
Visible,
And I am audible?
audible.
Okay. Thank you, Dr. Waklu, for the introduction. A very good evening to all the attendees of the webinar session 6 organized by the IRA. And after 2 excellent speeches, we are moving toward our third topic, psoriatic arthritis. What would you target, interleukin-17 or TNF-alpha? And as you all know, both these drug classes, TNF-alpha and interleukin-17, has been approved for the management of psoriatic arthritis, whereas TNF-alpha, the first drug, was approved almost 17 years back. The interleukin-17 targeted therapy have been approved only since 5 years. So in this context, the TNF-alpha can be considered as the elder brother of interleukin-17 targeted therapies. But some of the recent studies have shown the comparable efficacy of interleukin-17 in combating many of the domains of psoriatic arthritis, and in some of the domains they have performed better. As you all know, psoriatic arthritis have different domains. The cutaneous and articular features are the main. Again, the articular feature can be of different subtypes, and the cutaneous features can affect the skin or nail. But this is not the complete scenario, but the cutaneous and articular inflammation can be incorporated into the broader concept of psoriatic disease, where in addition to joint and skin inflammation, inflammation of the eye, GI tract can also be present. A significant proportion of patients can have metabolic syndrome, and some patients may have psychosocial burden. So when we are addressing such a disease, we have multiple objects, and relief from the musculoskeletal and cutaneous activity and pain, improvement of the patient global and physical function, and also the quality of life, and resolving of the systemic inflammation should be our core target. Along with, there should have retardation of the structural damage at a reasonable cost. And any drug which can address these issues widely would be more acceptable to the treating physician. Before 2015, these drugs were the only biologics which were approved for the psoriatic arthritis. Etanercept was the first drug of the anti-TNF family, got its approval in 2003, and subsequently other biologics got their approval based on the important role of TNF inhibitor in the development of psoriatic arthritis. They have role in the pathologies of the cutaneous keratinocytes, in the synovial cell inflammation, and also osteoclast activation, thereby bone resorption. In 2005, when already 3 of the anti-TNF therapy were approved, a new subset of TH cell were identified, that was TH17 cell, and the major cytokine, that is interleukin-17, subsequently found to have same pathologic effect on the keratinocyte, synovial cell, and osteoclast. And in some aspect, they act synergistically with other cytokines, and in some cases, they may play a sole role. So after the studies which was first published in 2015, the future one, secukinumab, got their approval as a interleukin-17 targeted therapy, and subsequently ixekizumab got their approval in 2018. Fortunately, we have other 4 more classes of drug, but today's discussion is chiefly centered on a comparison between TNF inhibitor and interleukin-17 inhibitor based on their efficacy in different disease activity measures and radiographic progression, their safety profile, and cost effectiveness. The first 3 are very important while selecting a drug for treating certain condition. And lastly, there are certain examples where one of these drugs may be better than another. The efficacy endpoint was assessed on the basis of ACR responses and PASI responses, because these represents the musculoskeletal and cutaneous responses, and one used in most of the studies. Along with it, the resolution of dactylitis and enthesitis, as evident from different studies. So this is a summary of the ACR responses, and according to the time frame, I have organized them at 24 weeks. The data from the TNF inhibitor have been collected from different important trials like IMPACT trial, ADAPT trial, Rapid PSA, or Go Reveal trial. And anti-IL-17 targeted drugs, the data have been taken from either Future or Spirit trial. So if we look the ACR 20, 50 or 70 response, there is no gross disparity between these two drug classes at 6 months time frame. The 20 response is roughly around 55 to 60%, 50 response around 45%, and ACR 70 response around 30%. If we progress to 1 year data, again, there is no much discrepancy. TNF inhibitor and interleukin 17 targeted therapy, almost 60 to 70% patient achieved ACR 20 response, where the 50 response is around 50% and ACR 70 response again around 30%. But for a disease like psoriatic arthritis, we need long-term data because biologics or other drugs may have to continue for a long time. And this is a comparison of 2 5-year data, one for the golimumab from the Go reveal and another from the secukinumab from Future One. Compare the ACR 20 response, very same, ACR 50, very close, and ACR 70, 35% versus 36%, no gross discrepancy. It is important that we cannot say that any drug is superior or inferior based on this data alone, because these are taken from the different studies which are done in different settings with different methodologies. But just to get an idea if there is any gross disparity present or not. Let us look the PASI data. Again, according to the time frame, this is 24-week response from adalimumab and secukinumab. The PASI 75 and 90 response, which are the higher response for the cutaneous improvement. If we compare this data, there is no significant difference, though SPIRIT P1 trial with ixekizumab reported almost 5% higher PASI 75 and 90 response than secukinumab. At 2 year, the PASI 70 response are still higher in comparison to the 24-week. However, the secukinumab group showed somewhat better proportion of patients who are having PASI 75 and 90 response. If we compare the 5-year data, again, Go reveal versus Future One, that is golimumab versus secukinumab, we cannot see any significant difference between the cutaneous responses. Now, there are some indirect comparison of anti-TNF agent versus anti-IL-17 targeted agent by using matching adjusted indirect comparison technique, and most of which are published between 2018 and 19. This was secukinumab versus adalimumab in PSA, and it was shown that PSA patients who are getting secukinumab having a higher likelihood to achieve ACR 20 and 50 response, which was evident from week 16 and which was persistent to up to 1 year. A similar data was observed when was compared with infliximab, and it showed better response in ACR 20 and 50 from 24 to 52 weeks. And this is the comparative effectiveness of secukinumab versus etanercept. And it was shown that secukinumab 30, 300 milligram dose were associated with higher, significantly higher all ACR endpoints compared to etanercept, and it was at 24 weeks, whereas the 150 milligram dose showed a higher ACR 70 response, but at 12 weeks, there is no significant difference between these two drugs. Now, all these comparative efficacy assessment are not favoring secukinumab. Recently, this meta-analysis published in RMD Open in 2019, and for ACR response, they included 22 studies and 16 treatment regimen and showed infliximab to be the most effective, followed by golimumab and etanercept. And for PASI response, they selected 17 studies and 14 treatment regimen. Again, the greatest benefit was noted with infliximab, but it was not superior to ixekizumab. So data are confusing. So let's go to the head-to-head trial. And I have taken the image of Evander Holyfield versus Mike Tyson to represent TNF inhibitor and anti-IL-17, but this time they are fighting for good, not to shed blood. The first trial, EXIT trial, secukinumab versus adalimumab in biologic naive patient who are intolerant to synthetic DMARDs. The primary endpoint was not met, and the endpoint was superiority of the secukinumab over adalimumab for achieving ACR 20 response. And at 52 weeks, 67% of the secukinumab treated patient achieved this, and 62% of the adalimumab treated patient achieved ACR 20 response. There was no difference between secukinumab and adalimumab in all of the major musculoskeletal endpoint, that is ACR 50, 70, minimal disease activity, DAPSA remission, resolution of dactylitis or enthesitis, or improvement in the quality of life. However, secukinumab showed better result than adalimumab in various cutaneous responses like PASI 17 achievement, 90 and PASI 100 achievement. The discontinuation rate was also lower with secukinumab. But there are some criticism in this study. 300 milligram of secukinumab dose was used, but the usual recommended dose in biologic naive patient is 150 milligrams. So the performance of the 150 milligram dose was not addressed, and the proportion of Asian patient was only 4% in the secukinumab group. So this result may not be regenerated in Asian population. Interestingly, the composite musculoskeletal and stringent cutaneous response, that is a combination of ACR50 and PASI 100, was seen in significantly better or more proportion of patients treated with secukinumab. And in the second head-to-head trial, where ixekizumab were compared with adalimumab, this was endpoint, and this endpoint was considered as the primary endpoint. So adalimumab again in the battleground to represent his family, and these are all biologic naive active PSA patient. Importantly, the effect of concomitant methotrexate treatment on the BDMARD response were also assessed in SPIRIT H2H trial. In patients with ixekizumab, irrespective of the methotrexate use, a significantly higher proportion achieved the composite musculoskeletal and cutaneous responses. In adalimumab treated patients, significantly less proportion achieved the composite index without methotrexate, and with methotrexate there is improvement in the proportion. But keep this aside, there is no difference in the ACR50 response between these two drugs when used without methotrexate. Importantly, in this study, ixekizumab showed better result in ADA without methotrexate in achieving higher responses like the minimal disease activity, ACR70 response, nail psoriasis response, and improvement in the quality of life. However, no difference was noted in ACR50 response, and PASI 100 response was significantly more in the ixekizumab irrespective of the methotrexate use. Regarding radiographic progression, not much difference. This is the data from the Future 1 trial for secukinumab. The mean change in the total subscore, which is modified subscore from the baseline in the pooled secukinumab group, was very less, 0.08, and in 52-week it is again very less. The pooled data showing the progression rate is just 0.3. But we need for radiographic progression a more longer period. And the 3-year data for Future 1 trial showed almost more than 3-4% of the patient were radiographic non-progressor, irrespective of the prior TNF use. If we compare the ADEPT trial or adalimumab at 144-week period, almost same patient was radiographic non-progressor. If we take the data from the SPIRIT trial, there is no SPIRIT P1. There is no significant difference between ixekizumab progression and adalimumab progression rate after 24 weeks. And again, after 3 years, the radiographic non-progressor in the ixekizumab group was 70 to 80%, which is comparable to the secukinumab and the adalimumab data from the ADEPT trial. Now, in psoriatic arthritis, there is not only bone resorption, but there is also anabolic bone changes. And this PSA Trust trial addressed the effect of secukinumab on both the catabolic and anabolic bone changes, though the number of patients were limited and the study duration was much less, but they used a multimodalities of imaging technique to detect the synovitis, periarticular inflammation, bone erosion, and enthesiophyte formation with secukinumab treatment. And it was shown that MRI synovitis and PDS signal significantly decreased with secukinumab at 24 weeks, and bone erosion and also the bone proliferation was halted by secukinumab therapy. However, we don't have a longer duration of this trial, and we don't have similar trial with TNF inhibitors. Regarding safety, both these drug classes have comparable and favorable safety profile. If we look at the EXCEED and SPIRIT H2H trial, there was no significant difference between overall and the severe adverse event. But in SPIRIT H2H trial, if we look, the nasopharyngitis proportion was slightly higher in anti-interleukin 17, major adverse cardiac event in 2 patients with TNFI, but in the EXCEED trial, it was seen in 2 patients with secukinumab. malignancy in 2 patients with adalimumab, but in exit trial, malignancy was seen in 2 patients with secukinumab and 3 patients with adalimumab. Yes, the IBD reactivation and injection site reaction was more in patients with ixekizumab. So in TNF inhibitors, the slightly increased risk of serious infection is there. Reactivation of tuberculosis, infection reaction, and malignancy are the possible major adverse event which to be considered during their therapy, whereas interleukin-17 inhibitors are associated with slightly higher rate of nasopharyngitis, candidiasis, neutropenia, IBD flare, and injection site reaction, which is common for the ixekizumab. EXCEED and SPIRIT H2H. In EXCEED trial, the drug discontinuation due to adverse event was slightly more for adalimumab than secukinumab. However, it was not significantly different in the SPIRIT P1 trial. And as we all know, the anti-drug antibody formation is slightly higher for adalimumab and infliximab. Secukinumab may have the lowest. Cost effectiveness for this analysis, I have included 4 trials, and secukinumab were compared with other TNF inhibitors and other drugs. And the results are almost same. This is a study from the Finland, which showed that among all the biologics, secukinumab was most likely to achieve or to give the net monetary benefit. This is a Canadian study. Again, for achievement of a highest number of quality of life, secukinumab was the most cost-effective drug as they determined. This from South America and Argentine study. Secukinumab is the most cost-effective treatment option, both in biologic naive and experienced patient. And study from Europe, the German study again showed secukinumab to be the most cost-effective one. So after this, let us summarize the difference between anti-TNF and the anti-IL-17 for articular and periarticular manifestation. I think there is no significant difference as far the data available so far. For achievement of the articular responses and quality of life, significant improvement without methotrexate use, probably IL-17 targeted therapy like ixekizumab may be better than adalimumab in achieving the higher musculoskeletal responses, and the pooled data from the future 2 to future 5 showed that secukinumab is also effective without methotrexate for cutaneous manifestation and for a combination of ACR50 and PASI 100 response, that is a stringent articular and cutaneous response. Undoubtedly, data available so far in favor of the interleukin-17 targeted therapy, but there is no significant difference in radiographic progression between these 2 drugs. The safety issue, each drug class have acceptable but slightly different safety profiles, and cost effectiveness. Data from other countries are in favor of secukinumab, but Asian country data are lacking, and data for ixekizumab is also lacking. In the last part, I will just explain 2 to 3 special situations. Psoriatic arthritis patient with history of acute anterior uveitis. Theoretically, both Th1 and Th17 subsets are responsible in autoimmune uveitis, whereas Th17 cell causes the inflammation in the early stage, Th1 seen in the late stage. TNF inhibitor are already approved, but 3 phase 3 trials, that is Ensure, Endure, and Shield, failed to demonstrate the efficacy of secukinumab because the pro-uveitic role of interleukin-17 is still not clear, and they may have a beneficial role in the disease. Psoriatic arthritis patient with active IBD. Theoretically, interleukin-17 has a role in maintaining the mucosal integrity by its action on the occludin protein. So treatment with anti-IL-17 targeted drug may target the IBD. Though in studies, the IBD flare was low, but patients with active IBD were not recruited in the studies with secukinumab. In this situation, TNF inhibitors is better. And important for our country, PSA patient with history of tuberculosis, as we all know, TNF increases the phagocytic capacity of macrophages, so their neutralization may have the possibility to reactivation of the latent TB. Long trial data from the adapter Go reveal did not show much TB reactivation, but there is no TB reactivation in anti-IL-17. So in this scenario, anti-IL-17 may be better. So at last, currently both TNF inhibitor and interleukin-17 targeted therapies are the 2 most important biologics which are being used for the management of PSA. Undoubtedly, for cutaneous response, interleukin-17 targeted therapy outperformed TNF inhibitor, and secukinumab is probably the most cost-effective. The adverse event profile of these two drug classes are slightly different, which should be kept in mind while choosing any drug. And ultimately, it is not TNF inhibitor versus anti-interleukin-17. It is, you have to just choose the appropriate one in a given setting to get the maximum benefit. Thank you for your patience, and I want to convey my sincere thanks to IRA for giving me the opportunity to be a speaker in this prestigious platform. Thank you.
Thank you, Dr. Mandal, for that very informative and very detailed comparison. We have 3 questions, but we are running short on time. So I would request you to answer the questions by Dr. Saurabh Malviya, Dr. Ajesh Maharaj, and Pankti.
Okay, sir. Okay.
Yeah. We would go on to our last, but not the least presentation. It's my absolute pleasure to introduce Professor Vinod Chandran, who has been my teacher so far as psoriatic arthritis is concerned. Vinod works in the Department of Medicine, Division of Rheumatology, Center of Prognosis Studies in Rheumatic Disease. He co-directs the psoriatic arthritis program in the University Health Network. And his topic today will be psoriatic arthritis, outcome measures and assessment in real life OPD. Over to you, Vinod.
All right, so thank you. And I can see there are more than 100 participants, and I gather this IRA webinar series is quite popular. And I understand this is the last one for some reason. I've heard that Indians have declared COVID-19 to be over. Here we are still stuck with it. So everything here is still in Toronto, still quite locked down, and hopefully things will get better over the next 6 to 9 months. And we can all meet in person, maybe end of the year or maybe next year. So what I've been charged with doing is to talk about assessment of psoriatic arthritis in a real life OPD. So after all the heavy data related talks that you all listened to, this hopefully is light on your intellectual bank. And so towards the end of the day, when you're all ready to go to bed, you can relax and think about how you see patients in psoriatic arthritis, and hopefully use some of it in your practice. So what am I going to do? I'm going to talk about briefly, you all know that it's about psoriatic arthritis, talk about assessment domains, treatment domains, and assessment of individual domains, composite indices, and decision making. And I recognize that some of these can't be used in clinic, but we need to review what the ideal way of, or the proper way of assessing psoriatic arthritis is, and then see how it can be used practically in our quite busy clinics. So this is a slide from Professor Oliver Fitzgerald, who's a colleague and friend from Dublin, Ireland. And as you can see, the disease is quite heterogeneous, right? From the skin disease, joint disease, axial and peripheral, and PCL, the progression of joint damage, nail disease, dactylitis, eye disease. And so how do you make the assessment simple and practical when the disease is complex? One thing to remember, of course, is clinical practice is many times very different from clinical trials, where the patients are quite homogeneous, so that you can get a signal out of all the noise. And in clinical practice, there are manifestations which we may not be counting in when we do a formal assessment for a clinical trial. For example, chest wall involvement, uveitis, all that is not part of the actual assessment in clinical practice, but in clinical trial. But in clinical practice, that patients sometimes have predominant chest wall involvement, and then those joints are not in a joint count, right? So it's going to be you have to tailor your assessment to that particular patient. You saw the slide before, and this is the GRAPPA-OMERACT core domain set. And this is mainly for clinical trials and for longitudinal observation studies. So what's in the center is the core domain that should be assessed in clinical trials and longitudinal observation studies. And the musculoskeletal involvement is the most important, obviously. It's recommended the other measures: skin, pain, patient global physical function, quality of life measures, fatigue, and systemic inflammation always be assessed in clinical trials. And then the second circle, economic cost, just like you discussed in the other talk, joint damage mainly by X-rays, and maybe soon by other imaging modalities. Emotional well-being and participation B is recommended that it be included. And the outer circle, stiffness, independence, treatment burden, sleep, they're all in the research agenda. So the main focus is that you try to do these in clinical trials, what is there in the center, and then ideally adapt some or most of those measures into your clinical practice. And here, the focus, of course, is as rheumatologists with seeing patients with psoriatic arthritis, we're primarily concerned with the musculoskeletal disease activity. Now, this is the GRAPPA treatment recommendations, and it's being revised, and you'll probably get to see the new one later this year. This is published in 2016. And it's not important. What I'm trying to show here is not the different treatments for different manifestations, but the concept that in a complex disease, you would want to kind of deconvolute the complexity into multiple domains and then evaluate that domain in quite much of detail so that you can assess how active the disease is. And it's also important to also evaluate other domains. So a patient comes to you with bad joint disease, you assess that, you assess all domains. Here there are the 6 domains: the peripheral joints, the axial joints, enthesitis, dactylitis, skin and nails, and then decide what is the most pressing problem for the patient. So it becomes very individualized. And then you assess all the other domains and choose a treatment that would take care of the primary problem, but also help the other domains if they're involved. And this is also important because sometimes you have discrepant responses, that the skin responds, but the joints do not, or vice versa. And then you would want to choose a treatment taking all that into consideration. And of course, the 6 domains here do not look at the other domains which are less common, for example, uveitis and IBD, but that also becomes an important consideration in individual patients, where you're going to personalize that patient's therapy compared to looking at data on groups of patients like in clinical trials. So let's look at these individual domains and how should we evaluate these domains. Now for joint counts, for looking at joints, we do joint counts, which most of the other specialists kind of laugh or make jokes about. Oh, these guys, they all always counting joints. But we think it's an important measure of the degree of involvement, the severity. And there are, the debate between the 28 joint count, which is a simple measure, versus the more extensive joint counts, the 66, 68 or 76, 78. Now, the difference between these joint counts is shown here. What we recommend is a 66, 68 joint counts, which does not include the CMC or the toe DIP joints. CMC joints, the first CMC joints are quite often involved in osteoarthritis and occasionally in psoriatic, but it's hard to differentiate. And the IP joints, the toes are quite close together, and so it's always hard to distinguish PIP versus DIP joints in the toes, and so we basically look at either one of those involvement. And then problem with the 28 joint count is that a lot of disease in patients is in the lower limbs, and so if you don't examine the feet, you're going to miss a lot of disease burden, and so it does not have a face validity. Although in clinical trials where there are 20, 25 joints involved, they perform reasonably well compared to a 66, 68 joint count. But in clinical practice, it's important to look at the 66, 68 joint counts, which means, of course, is that from a Western concept and maybe in the urban Indian context, patients would have to remove the shoes, remove your pants or pull up your pants to really look at it. And if that's going to take time, it is what it is. And you need to evaluate those joints when you evaluate psoriatic arthritis. So then the other important measure is enthesitis, which is very tricky because although we believe enthesitis is quite important as a pathogenetic mechanism, clinically assessing enthesis is quite difficult, and there is poor correlation between imaging and clinical measures of detecting enthesitis. Basically, pressing at these spots with your thumbnail to blanch the tip of the fingernail. Probably Professor Uppal is here. He's an expert in ultrasound, I believe, and so maybe make the distinction in clinical practice whether it's just tenderness without inflammation and versus inflammation. You might want to do a point of care ultrasound. Of course, that again is time consuming, and you might want to do that for some of your patients, the difficult ones, or patients who come to you predominantly with enthesial pain. And we recommend the SPARC enthesitis index, which is generalizable because it's not only for psoriatic arthritis, but also spondyloarthritis, including ankylosing spondylitis, and is more sensitive to change. And these are the spots of the SPARC enthesitis index, which is, there are 18 spots, so 9 on each side. But the score goes from 0 to 16 because if you have both the lower border of the inferior patella and tibial tuberosity, you only count one of them. Other spots being the greater tuberosity of the humerus, lateral epicondyle, medial epicondyle, greater trochanter, and so forth, listed over here. Now you might ask me, there are so many spots, what is the most commonly involved? And that is the Achilles and plantar fascia and the lateral epicondyle of the humerus. And this 4-point enthesitis score over here that has been used in some clinical trials involves 4 of those 6 sites. So it's important to evaluate it. You might want to choose your most favorite one. Even the leads, which is again only 6 spots, may be good enough just as a reminder for enthesitis assessment. Once again, clinical trials, you do a standardized assessment, so we can choose one of these. But in clinical practice, you might have an enthesis which is not in part of this and may need to be addressed specifically. Then the dactylitis assessment is important. One, dactylitis meaning swelling of the entire digit. And there are many scores that have been proposed. The dactylitis count, so count your fingers and toes. Initially, you have to have a visual inspection because the whole finger or toe has to be swollen. Now, it's hard to find a swelling of the entire digit. So if 2/3 of the finger or toe is involved, then that's good enough. But most importantly, the swelling has to be between the joints. So that if the predominant swelling is at the joint only, then it's arthritis. Whereas for dactylitis, you have to have it between the MCP and PIP or PIP and PIP. Now, for the dactylitis count, there is a debate whether you want to involve all dactylitis, meaning tender and non-tender, or just the tender. Of course, when you have non-tender dactylitis, many times with treatment, the swelling does not really go down. And what improves is actually the tenderness. The swelling might decrease slightly, but sometimes the swelling is just chronic. And once again, here imaging might be useful to actually determine if there's a lot more inflammation there. There is also this dactylitis severity score where each digit is scored from 0 to 3, no, mild, moderate, and severe. And then you get a total score of 3 times 20, that is 60. And then the Leeds dactylitis index, which is a little more involved. You take the diameter of the affected toe or finger compared to the opposite side, take the ratio multiplied by tenderness, if present or not. And then you get a score, which is used in clinical trials. You have to use a standardized instrument, which costs about 60 pounds. And so, or 25 pounds per shipping. So not quite practical. I think one of the dactylitis counts mentioned here is good enough in your busy practice. Spinal assessment, big challenge. All the assessments have been borrowed from ankylosing spondylitis. And although these have been used in clinical trials, it's very hard to distinguish the response overall from response in the spine. And there is a lot of research going into this now, but it's the problem with these assessments is not specific for psoriatic arthritis or psoriatic spondylitis, and it could be just improvement in inflammation overall. Improvement in peripheral arthritis would also improve the BAS dietary fat. Now, coming to psoriasis, the most common form is the plaque psoriasis, and most of the measures like the PASI and all that is used for that particular measure. But of course, our patients come with different forms. You have inverse, erythrodermic, pustular, and guttate, and these measure for, especially for pustular, these PASI is not a good measure. And one simple measure, of course, would be looking at the body surface area. To remember that the patient's palm, the whole palm, so including the fingers of the patient, is 1% of that patient's body surface. So you have to look at the patient's palm, the whole palm, and then estimate the effect of psoriasis all over the body and count the percentage. And that's pretty easy to do and is part of many of the outcome measures. And so that's something that can be done. Other thing to do is the physician's global assessment, where 0 is clear, and 1 is almost clear, and then mild, moderate, and severe. And the aim in clinical trials is to get to a score of 0 or 1. And it's been shown that if you multiply the PGA and to the BSA, you get a very good responsive measure. So if you have your global assessment and the body surface area, you can have a very good assessment of the extent of severe psoriasis. And this is the PASI. I won't go into details here, but essentially you're dividing the body into head, upper limb, lower limb, and trunk, and there is a calculation involved. With calculating apps, it's not a big problem. You just have to, each part you have to decide how much of erythema, induration of or scaling is there, and then multiply it. You can look it up, but it's quite, and we can discuss it if somebody's interested. But this is the measure that's usually used in clinical trials. The score can go from 0 to 72. This is an example here. But hardly see PASI above 40 in any trial or in clinical practice. And when you say PASI 75 response, you're seeing if there is a 75% improvement, and then dichotomizing that as yes or no. So if a PASI of a patient goes from 20 to 5, that's a 75% improvement, and you get a yes on the clinical trial. But in practice, of course, what patients need is clear or almost clear, and so that's probably an easy measure to do. And the body surface area, if you're going to do a composite index. Nail assessment is also sometimes quite complex. So you have the nail matrix and nail bed inflammation. Once again, you could simply use a global assessment and track it. These scores are probably more practical in clinical trials. Now, it's important to look at the patient's point of view. And so these have to be validated in that particular setting, language. There are so many other issues to be evaluated here. So you need to look at the patient global assessment of disease activity, pain, health-related quality of life, and there is a PSAID instrument that was developed specific for psoriatic disease. You can assess physical function with HAC, assess fatigue, emotional well-being, and participation. So, and again, in practice, you've got to develop appropriate instruments for your practice, and I believe that is some activity on that front in many centers in India. Language, even English language between, say, England and Ireland, or England and English Canada is so different, and that some of the words that we use have to be appropriately changed for that particular context. Then, of course, systemic inflammation. You look at the CRP, which is recommended, recognizing the fact that many patients have a normal CRP. And then there is a physician global assessment. People say, oh, it's a PGA, it's simple, it's just a 0 to 1 measure. You can, get that done in a second. But then how do you get a PGA? You have to actually do all the things that I've mentioned previously. You do all the joints, the skin, enthesis, spine, listen to the patient, get an idea of their complaints, and decide whether it's how much is activity, how much is other things that is going on. Look at the CRP, and then come up with a number. So it's a really complex number that reflects the years of training that we've all undergone evaluating the disease. So it's not a simple measure, although end of the day, it's a measure from 0 to 10. So how do you simplify this for the clinic? I would say it's important to look at all the domains, because as mentioned, we have to think about treatment as a next step. You're doing this assessment, you're planning a change in treatment. That's why we do the assessments, and for prognostication, of course. So peripheral arthritis recommended is the 66, 68 joint count. Dactylitis, you can count the digits of dactylitis, especially tender dactylitis. Enthesitis, the SPARC index is recommended, or at least look at the heel indices and the elbow enthesis. Axial arthritis, if no back pain, then I wouldn't worry too much about it. If there is back pain, then you've got to differentiate inflammatory mechanical, although we have shown that without imaging, it's really hard to distinguish that, because a lot of people with psoriatic arthritis have mechanical sounding pain, but could have inflammatory disease. Evaluate psoriasis with body surface area or physician global assessment. Look at the number of fingernails with psoriatic nail disease. Then you can have a global assessment. You can have an MSK and skin and a combined one. Figure out what best patient reported outcome that you want to use. And then CRP. Other things for stratification, of course, is X-rays to look for involvement of the peripheral joints. Is there erosions or not? Because that could help you with your treatment decisions. Spinal involvement, if suspected, but I always get at least a baseline involvement X-ray of the spine, SI joints, and lumbar and cervical spine in all patients. And X-rays of the peripheral joints also at baseline, and maybe every 2 to 3 years on follow-up. And of course, in your practice, you might be using more dynamic images, like imaging like ultrasound, so you might want to do it when appropriate, especially when you have a clinical testing. There are composite indices. I don't want to spend a lot of time here. These are the ones that I've listed here. Some of them I can briefly, this is something that is being increasingly used. The calculation is complicated, but again, you don't really have to worry about calculations nowadays if you just have a phone to do that for you. And you can categorize your disease into if it is less than 3.2, this is 0 to 10 score. There's low disease, and more than 5.4 there's a high disease, and in between is moderate disease. Not used in clinical practice, quite complicated, because in addition to all the thing, you also have the SF36 scores, and so it's not just simple clinical measures. Quite popular is the DAPSA, where you basically count the joint counts. Once again, 66, 68 joint count. You do a patient global, ask the patient for that. Patient pain, again, you're asking the patient, and the lab CRP. You can also have the clinical DAPSA where you don't have the CRP. Not much of a difference, because the CRP does not really play a big role in assessment of PSA. And you have the score for the DAPSA. 0 to 4 is remission, more than 28 is high, and the other scores are on the screen over here. And for comparing within a patient, this is quite useful. But again, you're only focusing on the joints here, which is a problem. What we recommend is a minimal disease activity criteria. Now, this is not a disease activity measure. It is a measure of an outcome. So basically, there are 4 physician-derived measures and 3 patient-derived measures. So patient comes to your clinic, you can ask your administrator to ask them to fill up the pain and global disease activity and hack thing, and then you can see them. You can do the joint counts, look at the skin, look at the enthesis, and then come up if you satisfy 5 out of the 7 criteria, you're in minimal disease activity, shows that long-term outcome is going to be good. If you want to make it more strict, you can do 6 out of 7, which is the low disease activity criteria, and 7 out of 7 is a very low disease activity criteria. You can choose your favorite, but the most validated one is the MDA. But of course, depending on your patient's question, you need to dig down and figure out why the pain is 100 if the joint counts are 0. So don't blindly use these measures. You need to understand them better and get that interaction with your patient to figure out especially when there is a disagreement between your assessment and the patient's assessment. So in practice, what is the goal? We're trying to determine disease activity status to consider change in treatment. And this change need not be always escalation, but also be, withdrawing treatment, because, phase that nobody wants to be on treatment forever. But if you're doing really well, you can start withdrawing treatment. And there are a lot of debate on how to do it. How long should we wait before you start reducing treatment? Should we stop or should we taper? Or should we spread out the dosing, etc., especially with biologics? And an important thing I want to emphasize here is the shared decision making. You've got to do your assessment, understand what your patient is doing, and then come together to a common agreement. And of course, here we just talked about the joints and skin, but how much of damage is present, what comorbidities are, and other socio-economic and other factors always play a role in clinical practice, which is really not really discussed during clinical trials and studies. So what are your approaches? You could, I prefer this domain-based approach. So you evaluate peripheral arthritis, axial arthritis, enthesitis, dactylitis, skin, nails, and other domains if they're involved. Look at the comorbidities, the degree of damage at baseline, and then depending on what most most active domain is, you treat that domain, keeping the other domains in mind, and then also at the same time try to aim for a target. An MDA is a good target, and if it's an early disease, you could even target 7 out of 7, which is a very low disease activity criteria, and then hope to use the domain approach to achieve a target. And once you reach that target, again, discussing with your patient, you might want to start then considering reducing the intensity of immunomodulatory therapy. So with that, I think I'll stop here. We're happy to take any questions. Just what I've discussed is that it's hard to evaluate a heterogeneous disease, be it lupus or psoriatic or most of the diseases that we deal with. You need to have a plan in mind. This is the domains, both from a patient perspective as well as the treatment perspective. And then think of composite indices, and I would say use one of them as a target for treatment. MDA is useful, and the decision making ultimately is a shared one with your patients. And with that, it's a picture of a group here in Toronto. We have clinicians here. You can see Professor Gladman there, Dr. Eder, Dr. Rosen, who's a dermatologist, statisticians, Dr. Cook and Farewell. Anupam used to be there in this crowd some time ago. We have trainees, and of course, we have patients within our own research group. You'll also see Ashish here, who was here with us last year. With that, I'll stop and happy to chat.
Thanks, Vinod. Concise and very lucid presentation. We have one question, and because we are beyond 9 o'clock, I would be grateful if you could answer it in the question and answer chat area. Thank you everybody for this webinar, and I would now hand it over to Professor Alakendu Ghosh and Dr. Sapan Pandya.
Yeah, Sapan, you can conclude. Yeah, Vinod, thanks a lot for a wonderful presentation.
Thank you. There is just this one question. Maybe Vinod can take it up here itself. Dactylitis and joint counts. If yes.
Sure. Yeah. So what in our practice, it's been a debate whether in the dactylitic finger do we count those joints in the joint count. So we do, because in our own studies, when you look at joint damage over time, in a dactylitic joint, the swollen joints is the one that drives the joint damage. And yes, I think we should count the joint. Even if a finger is dactylitic, you count the synovitis, and all of you who do ultrasound would know that most of these patients have synovitis. So we count that, and also count it as a dactylitis, because although they might count it double counting, the dactylitis is a mix of synovitis and enthesitis. And so yes, I would count both.
Thanks, Vinod. So this happens to be the last webinar, as Vinod said, and as he also probably questioned, I think looking at the success of the webinar, President Sir, with the people like Dr. Anand Malavi and Dr. Ashok Kumar logged in and asking questions, I think it's indeed a matter of great pride for us. So I think maybe we should rethink and have, we can have feedback from all of you, all the attendees and all the people from IRA members, and if we feel we can still have maybe focused 1 or 2 sessions, 1 in 2-3 months till the COVID is really out. as we know, also suggested. I take this opportunity to thank today's sponsors, IPCA, and all the sponsors till now, all the industry, because of this, this has been possible through the year. I also would like to thank all the speakers today's speakers, Vinod, Sumantro, and the rest, and the chairpersons, Vikas sir, Abel, Anupam, and Sukhbir sir for moderating and speaking, and all the speakers in the past. We gathered through this session, because of COVID, we were able to do webinars, and we gathered, like the IPL, there were so many youngsters who are such good speakers. Even the IRA scholars meeting, Alkendu sir will agree that we came out with such eminent and not only just eminent speakers, but also youngsters who were speaking really well, who know their stuff. So I think this has been a sort of a discovery for us, and we hope to have them in the future as well. All the moderators, as I said, I would also like to thank Shinoy and his team, Deepu, Nitin, Linda, and all of them who have done an excellent job. And so it's a request to all of you to look at. There was this question whether these webinars will be available, the recordings will be available. So I think they will be there on the website, at least for some time from now. So I request all of you to keep looking at the website and looking at the newsletter for further information from the IRA. The President sir has also asked me to share that we have been doing other academic activities also. This will also continue till we have the IRACon. We will continue some other sessions in some other form. And as part of research, also we have these grants, as you know, which we are now doing on a monthly, or you can apply at any time. It's just that every 2-3 months we have these round of people look at those grants. There are patient awareness meets also ongoing, which by month we will be having at least. We've shared that in the IRA WhatsApp group and the email as well. And also there is a COVID registry, which the Karnataka group was looking at, and I hope that some data will come out of that. We are also having the IRA database. We're trying to form that as well. So I think with best wishes to all of you, that all of us mount good antibody responses, as Abel suggested, and that including the mutant variants. I hope that we are able to meet at the IRACon this year. It's been a while. I would want Alkendu sir to finally say a few words, and we'll end there. Thank you.
Thanks to all of you. And as Shapon has summarized, from my side, I want to reinforce special thanks to Shapon and Shinoy. Shapon is visible, Shinoy was invisible. But this visibility and invisibility making a great impact for conducting this all these sessions throughout the year, at least last 6 months. When we faced the challenge that COVID landed and everything stuck up. So initially we had really trouble how to go ahead. Then ultimately we could come up, and as Shapon was suggesting and telling, that you could explore and you could identify a lot of talents from Indian Rheumatology group, and we have really a successful academic interactions from all the people. It's really a great event. So thank you so very much to all the national and international speakers and chairpersons. So I think we'll have a very nice time. Thanks a lot. Good evening. Have a wonderful weekend.
Hope to see you all in December. Thank you.
Thank you very much.
Bye-bye.